Yes, we can start now.
Vishal sir, can I start?
Yes, go ahead, Ankur.
Yes, sir. Hello, everyone. Welcome to the Research Society of Anesthesiology Academic webinar series. And today we are live with one more important topic to discuss, which is the pediatric traumatic brain injury. And this is being hosted by RSA Guwahati City branch. I thank our President sir and our Secretary sir for this kind opportunity, and I'm sure this topic would bring lot of insights into the understanding of pediatric traumatic brain injury and its management and its rehabilitation. To discuss the topic, we have eminent chairpersons with us. We have prolific speakers with us today who will be taking us through the thicks and thins of pediatric traumatic brain injury. But before we begin the webinar, it's my honor to invite our President sir, Professor Naveen Malhotra sir, to kindly address the austere gathering.
Thank you, Dr. Ankur, and heartiest congratulations to RSA Guwahati City branch for organizing this webinar today and on the auspicious occasion of Eid al-Adha, and greetings for the same. And I'm very happy that Dr. Swati and Dr. Mayank are chairing this session, and Dr. Barkha Bindu, Dr. Shishan, and Dr. Sen Gupta have agreed to spare their valuable time to deliver this important talk. So I take this opportunity to welcome you all to the annual National Conference of Research Society of Anesthesiologists, uh, scheduled on first weekend of April at Lucknow 2027. And I'm happy to share with you that today after tomorrow on Saturday, there is an RSA sponsored CME workshop at Tumkuru, Karnataka. And profuse congratulations and greetings to Dr. Nani Raghunandan for working towards the CME and workshop for the last more than 1 month. And around, you will be happy to note that there are around 200 registrations already done. And he has invited faculty from Pan India, including our secretary and joint secretary will be representing Research Society of Anesthesiology. Dr. Swati and Dr. Vishal will be personally there, and the organizing secretary, Dr. Nani Raghunandan, has kept a very, very interesting scientific program and 5 workshops. So imagine conducting 5 workshops on a single day, and and a good spirit-free dinner on Friday. So those of you who are attending, I convey my best wishes and greetings. For some personal reasons, I'm not able to travel, but my soul and my heart is there, and my video recording will be there to be shared with you all. So God bless you all, and best wishes to the speakers and the chairpersons. Over to you, Ankur.
Thank you so much, sir, for your kind words and taking us through the achievements of RSA, and best wishes to Raghu sir for the forthcoming conference in Karnataka. May I now invite our Honorary Secretary of RSA, Vishal Sangla, sir, to kindly address the gathering.
Good evening, sir. Good evening, everyone. And it's my privilege to be part of this academic series. I would like to congratulate Team Guwahati, Dr. Ankur Khandelwal and the team to host this wonderfully crafted webinar series. I would also like to welcome our past president, Dr. Indrani Hemant Kumar, who has joined us for this academic webinar. And all the best to Team Guwahati. Thank you very much.
Thank you so much, sir. I also thank Indrani ma'am for joining the meeting, and I'm sure she would have definitely some insights in between the webinars from her end. May I now request the chairpersons, Dr. Swati ma'am from AIMS Jodhpur, who is a faculty and additional professor in the Department of Anesthesiology and Critical Care, and Dr. Mayank Masand sir, who is from Indore and is currently working as consultant in Vishesh Jupiter Hospital, to kindly chair this forthcoming sessions on three important topics of pediatric traumatic brain injury. I welcome Dr. Swati madam and Dr. Mayank sir for chairing this session.
Thank you.
Thank
Yeah.
First, you go ahead, Dr. Swati, please.
Yeah, thank you very much, Dr. Ankur, Dr. Naveen Malhotra sir, Dr. Vishal, Indrani ma'am is here. Good evening, everyone. Thank you for making us a part of this academic session today, and congratulations, Team Guwahati, for getting the best speakers of national and international repute on this platform to discuss a very important topic of pediatric TBI. Dr. Mayank, over to you. And could you please introduce the first speaker and the first topic also?
Yeah, sure. Thank you so much, Dr. Swati. It is a real pleasure to have to be in this particular session. Thank you so much, respected Dr. Naveen Malhotra sir, and Dr. Vishal Singhnathan, respected Dr. Indrani Hemant Kumar ma'am. All the best to all the speakers, and many thanks to Dr. Ankur Khandelwal for making us a part of this academic session. As we all know, traumatic brain injury definitely carries a lot of variety. The management totally differs when we are dealing with two defined age groups, adult as well as pediatrics. So today our concentration is mainly on the pediatric age group, and our first speaker would be Dr. Barkha Bindu from Delhi, and she will be speaking upon the initial assessment and emergency stabilization in the case of pediatric traumatic brain injury. Over.
Good evening, everyone. This is Dr. Barkha. Thank you so much for giving me this opportunity. I hope the screen is visible.
Yes, ma'am, it's visible. You can proceed.
Okay. So next 15 to 20 minutes, we will be talking about initial assessment and emergency stabilization of pediatric traumatic brain injury, with the focus being on mitigating secondary injury and preserving neurological function. So let's start with some facts. It is estimated that the global annual incidence of pediatric traumatic brain injuries ranges from 47 to 280 cases per 100,000 population. And in children younger than 14 years of age, there are approximately 2,000 deaths annually because of pediatric TBI in the US. Now, pediatric TBI shows bimodal peaks of incidence. The two peaks at which the incidence is highest is at less than 2 years of age and in the adolescents. Most common causes of pediatric TBI reported are falls, sports-related injuries, being hit on the head, injuries involving bicycle and motor vehicles, especially as a pedestrian. Most common injuries reported in pediatric patients are STH, EDH, contusion, and concussion. The risk factors why these pediatric patients are at a higher risk of more severe traumatic brain injury is because of the unique pediatric anatomy. Further, fall from height of more than 3 feet, motor vehicle accidents, and high velocity projectile injuries also increase the risk of traumatic brain injury in these patients. The incidence of DAI and secondary cerebral edema is more in pediatrics than in adults. However, the neurosurgical intervention rate is rare, approximately 0.14%. So what is unique in pediatric patients? We all know there are a lot of differences in the anatomy and physiology between pediatric and adult patients. More important for traumatic brain injury point of view are that pediatric patients have proportionally larger and heavier heads related to their bodies. The skull is thin and can deform without fracturing. They have large surface area relative to body mass, so they're more prone to hypothermia. They have higher metabolic rate and oxygen demand. Total body water and brain water content is higher in pediatrics compared to adults. Cerebral compliance, which is modified by open sutures and fontanelles. ICP values in children are lower than in adults. Even small increases in ICP can have significant adverse effects. Cerebral blood flow is highest during the first few years of life and gradually decreases as the brain matures into adulthood. And then we also have to remember that there are age-specific blood pressure and cerebral perfusion pressure targets. So when a pediatric patient with traumatic brain injury comes to us, the important points that we need to take care of in history are the timing and type of accident, the degree of force which acted on the head. We need to remember that there are severe mechanisms which can cause severe traumatic brain injury, which are motor vehicle accident with patient ejection or rollover. If the child was a pedestrian or cyclist struck by motor vehicle, if there was a fall of more than 1.5 meters height, or if the head was struck by a high impact object. The red flags will be loss of consciousness or impaired consciousness, abnormal behavior like agitation, confusion, drowsiness, headache, nausea, vomiting, other injuries sustained at the time of injury, amnesia. And on physical examination, the red flags that need to be remembered are unilateral or bilateral pupillary dilatation, drop of more than 2 points in GCS, development of focal neurological signs, abnormal posturing, irregular respiration, bradycardia, hypertension. When such a child comes to the ER, specifically feel for palpable skull fractures, look for signs of base of skull fractures, which will present as hemotympanum, otorrhea, rhinorrhea, raccoon eyes or periorbital bruising, and bruising over the mastoid area or battle sign. So the priorities of initial management of these patients are that we all know primary injury is irreversible. The injury that occurred at the time of injury, at the time of impact, cannot be altered. What is preventable in these patients is the secondary injury. So the goal of initial management is to prevent anything that causes secondary injury to the brain. So the focus will be on preventing hypoxia, hypotension, uncontrolled ICP rise, maintaining CP to halt secondary damage. So primary survey starts with followed by ABCD. The first C is for catastrophic bleeding. If we need to assess the patient for any external sites of hemorrhage, which if present has to be managed with direct pressure or compression bandage and tourniquet for extremity bleeding. We need to check the patency of airway, whether the child is able to protect his airway, and if there is any loss of consciousness. So in case airway has to be managed, spinal motion has to if there is tachycardia, hypotension, cold, clammy skin, capillary refilling time of more than 2 seconds, we need to look for signs of sites of bleeding or hemorrhage. If we are anticipating a pelvic fracture, it has to be stabilized. If there
Excuse
is
me, your slides are not visible. Can you make it sharing again?
Is it okay now?
Please make it to the full screen, ma'am.
Yeah. Is it visible now?
Yes, ma'am.
Yes, please.
Visible.
Okay, so we were with the C component, that is circulation. If there is hypotension, tachycardia, cold clammy skin, we need to look for signs of hemorrhage. which has to be managed with crystalloid boluses initially of 10 to 20 ml per kg. And if that is not sufficient, we might have to move on to transfusion of blood itself at 10 to 20 ml per kg. If there is ongoing bleeding, it is better to replace with PRBCs directly instead of crystalloids. Now, coming to disability, if there is severe head injury, that is a GCS of less than 8, or if the patient is responding only to pain or is unresponsive, the first thing to do is contact neurosurgery, and then a sequence of actions that have to be taken, which I'll discuss later on. In case we are anticipating impending herniation, that is, if there is unilateral dilated or fixed pupil, or there is Cushing's triad, irregular respirations, then hyperosmolar therapy has to be given either with hypertonic saline or with mannitol, and a brief period of hyperventilation until the pupils become responsive. If there is neurogenic shock where there is hypotension and bradycardia, we might have to start inotropes to maintain the pressures. And for E, exposure, we need to prevent hypothermia. So this is the flowchart for assessment of pediatric TBI that is given by the Indian Academy of Pediatrics in 2022. It is similar to the one shared by the Brain Trauma Foundation also. So initial assessment of severity, that is the primary survey that we did of ABCDE. This is followed by calculating the GCS, which is pediatric GCS. So based on the GCS, pediatric TBI is then classified into mild, moderate, and severe. Mild is a GCS score of 14 to 15, moderate is score of 9 to 14, and severe is less than 9. So with a GCS score of 9 to 14, a CT scan has to be done. Again, the indications will be discussed in the next slide. And a neurosurgery consultation has to be given, and then GCS and vitals monitoring have to be taken care of. For severe TBI, there is a sequence of actions that has to be taken in baseline care, followed by first tier therapy for raised in RISE ICP, and for which, if refractory, we have to move on to second tier therapy. So the pediatric GCS, we are usually well versed with it. It is more or less similar to the adult GCS, just a few differences here and there. The eye opening is more or less similar between pediatric and adult GCS. About the motor response, is just the M6 response for children who are more than 5 years. They should be obeying commands. For children who are less than 1 year, it is spontaneous movement should be present. The differences come in with the verbal responses for patients who are more than 5 years, for those who are 2 to 5 years, and those who are less than 2 years. So the verbal response in these 3 age groups is categorized based on age appropriate responses. Now, the Indian Academy of Pediatrics also gives us some specific indications where intubation has to be considered for pediatric TBI patients. Those are absent gag reflex, for airway protection and mechanical ventilation in patients who have severe traumatic brain injury, and for patients who have poor breathing efforts. The precautions that need to be taken during intubation are we need to ensure cervical spine immobilization. The commonly used drugs are fentanyl, lignocaine, and with a muscle relaxant. NS may be used for bolus therapy followed by inotropic infusion to keep the hemodynamics stable. So when is neuroimaging done for patients with pediatric traumatic brain injury? These are the pick-and criteria for CT scan in pediatric patients with blunt head trauma. For children less than 2 years and children more than 2 years. For those who are less than 2 years, if the GCS is less than 14 or there is altered mental status or palpable skull fracture, CT has to be done. For those who are more than 14 with no altered mental status, no palpable fractures, no hematoma, no loss of consciousness of more than 5 seconds, but could be having a severe mechanism of injury or may not be acting normally, for them it is either observation or the need for CT depends on physician experience. For children who are more than 2 years, again, if the GCS is less than 14 or altered mental status or signs of basilar skull fracture, a CT is needed. If GCS is more than 14, but there is a history of loss of consciousness, vomiting, severe headache, severe mechanism of injury, again, it depends on the physician's experience. Now, the national guidelines for the management of TBI given by the Neurotrauma Society of India in 2022 says there is evidence that the radiation exposure from a CT scan can damage the brain of children less than 5 years old. But most modern CT scanners have pediatric settings to decrease this exposure, so we need to make sure that these settings are used. The NTSI does not at this time recommend MRI scans for children with acute TBI. Now, we did a primary survey Now, the ongoing care will include re-evaluation of primary survey and the interventions that we did there, re-evaluate the vital signs, and also manage pain at the same time. Meanwhile, we need to obtain chest X-ray, pelvic X-ray if the patient is hemodynamically unstable, we are anticipating some sort of fracture, and we might have to get an E-FAST also done. We have to manage pain. Fentanyl may be used if we are intubating the patient. Otherwise, we can use paracetamol or some other drugs for pain management. Most important is to identify the critical ICP or impending herniation features. The red flags for these are a sudden drop in GCS of 2 or more points, development of sluggish, asymmetric or fixed or dilated pupils, onset of Cushing's triad, hypertension, bradycardia, irregular respiration. If there is abnormal posturing, decorticate or decerebrate posturing, and if there are bulging fontanelle in an infant combined with altered mental status. So this is the flow chart given for pediatric severe traumatic brain injury. These are 2019 consensus and guideline-based algorithm for first and second tier therapies given by the Brain Trauma Foundation. So we know severe traumatic brain injury is a GCS of less than or equal to 8. So as we already discussed, a CT has to be done and surgery as indicated. For the BTF says ICP monitor has to be inserted. And the baseline care for these patients will include maintaining appropriate level of analgesia and sedation. Most common agents used are opioid plus benzodiazepine, usually midazolam combination. Controlled mechanical ventilation, ensuring normocarbia, normoxia, maintaining normothermia, preventing and treating fever, ensure appropriate intravascular volume status, maintain minimum hemoglobin of at least 7 grams per deciliter, treat coagulopathy if ICP catheter insertion is being planned, neutral head position with head of bed elevation, anti-epileptic drug therapy with phenytoin or levetiracetam, and use of continuous EEG monitoring is also indicated, and we need to treat both hypo and hyperglycemia. Now, this is the baseline care for patients with severe traumatic brain injury. Now, we can see in this pathway, there are 3 following pathways: the ICP pathway, the CPP pathway, and the brain tissue oxygenation pathway. But while all this is being done, we need to make sure we need to take care of the herniation pathway also. As we already discussed, the red flag signs of pupillary dilatation, Cushing's reflex, or extensor posturing has to be managed emergently with hyperventilation to a PaCO2 of 25 to 30 to reverse pupillary dilatation. Ventilate with FiO2 of 1. A bolus of mannitol or hypertonic saline has to be given. If an EVD is already in place, we need to drain CSF and get an emergency CT done. Now, next we move on to the ICP pathway. So the first tier therapies, the ICP pathway, if there is an ICP monitor in place which is showing a value of more than 20 millimeters of mercury for more than 5 minutes, the actions that have to be taken are, if there's an EVD already in place, drain CSF. This is the first thing to do. Start off with hyperosmolar therapy, hypertonic saline 1 to 3 ml per kg, maximum 25 ml over 10 minutes, followed by an infusion. The target has to be a sodium of around 160, less than 160, and an osmolarity of less than 360. In certain cases, mannitol may be indicated, which usually is not used in pediatric patients, but it can be considered if the child is normotensive, there's no kidney injury, and the serum osmolarity is less than 320. Mannitol is given in a dose of 2.5 ml per kg over 20 minutes. If in spite of all these steps, there are still additional spikes or progressive increase in ICP, we need to give additional boluses of hyperosmolar therapy. We need to add analgesia sedation, and we might have to start off with neuromuscular blockade also. If the ICP, in spite of all these efforts, continues to be refractory to first tier therapies, we may move on to second tier therapies, which the other speaker will speak about. Coming to the second pathway, which is the cerebral perfusion pathway, cerebral perfusion pressure pathway, we all know CPP is equal to mean arterial pressure minus ICP. So, in cases where we don't have ICP monitoring, here the CPP is thought to be maintained by maintaining a systolic blood pressure or mean arterial pressure of more than 50th centile for age of the child by titrating fluids. So a CPP target has to be achieved by giving fluid volume, fluid boluses. And in spite of this, if CPP target is not achieved, vasopressors such as dopamine or norepinephrine might have to be added. However, we need to remember that an approach that focuses exclusively on maintaining CPP is not acceptable, because herniation can still occur if there is raised ICP even when the CPP has been maintained. So all these pathways do not work in isolation, they all have to go together hand in hand. So this is the PBTO2 pathway. This is given by the Brain Trauma Foundation, which says that interventions that can specifically increase the brain tissue oxygenation, like increasing FiO2, increasing mean arterial pressure using vasopressors, increasing PaCO2 slightly so that there is cerebral vasodilation, which increases cerebral blood flow, and by optimizing hemoglobin. However, in resource-limited settings like India, this facility is rarely available. So the Indian Association of Pediatrics says since we do not have the facility of ICP monitoring very freely available to us, what to do in those patients, there is a lack of evidence. But as we already discussed in the chart, the baseline care continues to be the same, and it is more of clinical guidance to decide the further steps of action. So the summary of my presentation of initial assessment and stabilization of pediatric TBI patients: we need to protect the airway with cervical spine precautions. We need to maintain oxygenation, avoid routine hyperventilation. We need to maintain perfusion using fluids, and if required, vasopressors. Avoid hypotension, avoid hypoglycemia, avoid hypoxia. Monitor closely for signs of herniation, as we discussed, pupils, GCS changes, posturing. Act swiftly with 3% hypertonic saline, head of bed elevation for any ICP spikes, and expedite CT imaging and neurosurgical consultation. So these are my references: the Indian Academy of Pediatrics Guidelines of 2022, PTF Guidelines of 2019, the Neurotrauma Society of India Guidelines 2022, and the Canadian Pediatric Society Guidelines of 2025. The further discussion I'll leave to the next speaker. Thank you.
Thank you, Dr. Barkha ma'am, for the wonderful presentation. It's been absolutely very informative. We will take the queries at the end of the sessions, but then a few words from the chairpersons on this particular topic.
Yeah, excellent presentation, Dr. Barkha. I think you have covered everything which needs to be known, and very updated information. Thank you and congratulations for that. And as Dr. Ankur said, we'll take the questions and comments at the end of all the talks. Thank you.
I would like to, we have with us our past president, Dr. Indrani Hemant Kumar madam, and I would like to call upon madam to please say a few words. Madam, Dr. Indrani Hemant Kumar madam, please.
Good evening,
Can
ma'am.
we have a few words from you, ma'am, please?
Thank you, Vishal.
Very good evening, ma'am.
Very good evening. Very good evening. And I think this is one topic, people generally talk about adult TBI and, very little, information is spread about pediatric TBI. So excellent webinar. I'm just looking forward to listen to others also. And Barkha, you did a fantastic job of giving us the guidelines. And just looking forward to listen to the entire webinar, and excellently, done up topics.
Thank you, ma'am. Thank you for joining the webinar and for your kind words, ma'am. It's always a pleasure to listen to you.
You're rocking.
Thank you, ma'am.
Yeah.
May I now invite our second speaker for the evening, Dr. Jayant R. Sishan. He is a neuroanesthetist and is currently working as a faculty and assistant professor in the Department of Anesthesiology and Critical Care at JIPMER, Puducherry. A very, very intellectual guy. Over to you, Dr. Jayant. You can share your screen and begin your session.
Thank you, sir. I'm just trying to share my screen. Is my screen visible, sir?
Yeah, it's visible, Jayant.
Okay. Good evening to all. At the foremost, I would like to thank the RSAP for giving me this opportunity, and also to Dr. Ankur Khandelwal sir, who has been an excellent senior to us, and he has been giving us opportunities to shine in the field of neuroanesthesiology in the form of webinars and whatnot. So thank you so much. So my topic is about the neurocritical care and ICU management of severe pediatric TBI. Before we delve into it, just to recap the basics, pediatric patients and pediatric patients with TBI have unique challenges. They come with the anatomical and physiological differences owing to their body surface area, the immature musculature and bone development, their heightened compliance, which makes them more prone to compensate for a long period of time and then deteriorate drastically. And that is the point where intervention is required, or before that is where the immediate interventions are required. They have generally a higher metabolic rate and oxygen demand, and they do have difference in the cerebral blood flow, which means that the thresholds for any changes are very low, and we need to maintain them as close as possible to the baseline. And those are all the important challenges that come in the way of management of patients with pediatric TBI. So what is the goal of management of any patient with TBI, let alone pediatric, is the prevention of secondary brain injury. Secondary brain injury may manifest in the form of cerebral edema. It may be because of impaired autoregulation. Children in general have developing autoregulation. They have poorly controlled autoregulation. It can be because of ischemia, mitochondrial dysfunction, excitotoxicity, inflammation, seizures, and hyperemia or hypoperfusion. None of these are very well tolerated by the children, which means that all of them need to be prevented as early as possible or managed accordingly. So ICU management and in general management of severe pediatric TBI is a vast topic. Hence, we are going to discuss the key points, which include control mechanical ventilation, general principles of neurocritical care, including head and elevation, neck neutral, CSF drainage if an external ventricular drain is available, appropriate use of analgesic sedation, hyperosmolar therapy, maintenance of euvolemia, normothermia, avoidance of hyperglycemia, continuous clinical neurological monitoring, and prophylaxis with anti-seizure medications. These form the major points of ICU management of any pediatric patient with traumatic brain injury. So with this, let me introduce a case scenario. The images that are being projected are of a 7-year-old boy who had a road traffic accident. He was riding pillion with his father and he fell. He wasn't wearing a helmet. He was brought to the emergency department with a GCS of E2, V1, and M5. Protocols were followed, and he was immediately intubated in terms of low GCS, and a CT scan was then performed. So the preoperative CT here, or the ED CT here, shows that there is some amount of basal cistern compression. And as we move ahead, we find that some hypodensities are starting to develop in the right hemisphere. The ventricles are effaced, and there is a rim of right-sided acute subdural hematoma. This child was shifted to the ICU for conservative management because there was no significant midline shift, and the SDH was assumed to be of a thin rim, and he was not taken up for immediate surgical intervention. But a few hours later in the ICU, he developed one episode of GTCS, after which a CT was done, which showed an increase in the subdural hematoma, following which he was taken up for decompressive hemicranectomy. So post-decompressive hemicranectomy, a repeat CT scan was done, and that repeat CT scan was showing, as seen in the video here, the basal cisterns are opening up. You can see that the window of decompression is done, allowed for the brain to expand. The ventricles have started to go up, but he has developed hypodensities in the right PCA territory as well as over the right-sided hemisphere and extending slightly into the left side as well. But the gray matter, white matter differentiation in the cortical areas seem to be well maintained. So what we want to know is how this patient has to be managed in the intensive care unit, either before or after decompressive hemicranectomy, and what are the principles of management of these cases. So most of our information, most of the knowledge of management of these patients comes from the guidelines that have been produced by the Brain Trauma Foundation. The latest edition of guidelines of pediatric TBI were published in 2019. These were the third edition guidelines, and they had guidelines of around 15 different components of management of these patients. And unfortunately, none of them managed to provide high quality evidence or higher levels of recommendation. Most of them are level 3 recommendations, whereas level 2 recommendations were found with hyperosmolar therapy, temperature control, and the effect of nutrition in these patients. The rest were all level 3 recommendations, which were from studies which involve very limited participants or were designed the way they were supposed to be. So what is the cornerstone of management of these patients in the ICU is regular neurological assessment, which involves assessment of the GCS and the pupillary reactivity and to look for red flag signs. There are important differences in assessment of GCS between pediatric and adult, mostly in the form of motor response, and it was discussed by Dr. Barka, so I'm not going to go ahead into it. The important points are to look for motor response evaluation continuously, and any significant drop in motor response by 1 or the whole GCS, all 3 components of GCS by 2 points indicates that there is some neurological deterioration that is happening. So what else can we evaluate in clinical neurological evaluation? We should look for red flag signs. These red flag signs are usually a result of increased ICP or ongoing herniation. Transtentorial herniation may result in pupillary dilatation, bradycardia, and even respiratory disturbances that forms what is known as the Cushing's triad. Foramen magnum herniation can cause nystagmus, again bradycardia, bradypnea, and hypertension. If there is subfiles and herniation, it may result in motor weakness. So it is important to assess for paucity of movements on either side of the body as well. And as we know, decorticate and decerebrate rigidities are indicating different levels of brainstem dysfunction. One at the red nucleus level, which involves the corticospinal pathways, and decerebrate rigidity or the M2 response, which involves further lower down in the midbrain and in the mid-pontine levels. So all of these indicate that the neurological examination is worsening and it requires appropriate interventions. So what else do we need to do? So let us just summarize the guidelines on important topics for ICU management. We need to define ICP and cerebral perfusion pressure thresholds for these patients. The recommendations are all level 3. The ICP threshold recommendation is that any treatment of these patients should target an intracranial pressure level of less than 20 millimeters of mercury. Now, this level is different from the adult population, where the latest recommendation shows that the target should be less than 22 millimeters of mercury. But it is important to note that pediatric age groups in turn have different subclassification. They may be toddlers, they may be infants, they may be adolescents. So all of them have different anatomical and physiological changes, and hence the ICP thresholds may not be a gross reflection of the particular age group of the patients. So in turn, we need to have age-specific ICP thresholds as well. Coming to cerebral perfusion pressure thresholds, as we all know that CPP is MAP minus ICP. So we need to maintain a MAP that is significant enough to have a cerebral perfusion threshold of around 40 to 50 millimeters of mercury in these children. And this is also a level 3 recommendation. Now, this recommendation of 40 to 50 as a range has been kept to make sure that there are no significant hypotension episodes, which means that the CPP does not come to the lower limit of this 40 to 50 range. And any episode of hypotension, as we know, is going to worsen the neurological outcome. The lower limit of autoregulation of cerebral blood flow in TBI versus normal infants and younger children is similar. That means they have a very low threshold for maintenance of autoregulation. So it is important to maintain the blood pressure within the defined normal levels. How do you hemodynamically optimize these patients? The target should be euvolemia. Mean arterial pressure targets to achieve age-appropriate cerebral perfusion pressure. Now, this 40 to 50 has been given as a gross range, but there are different studies that have shown that the range may be more wider and with different age groups. The infant and toddlers may require a slightly lower cerebral perfusion pressure of between 40 to 45, whereas for adolescent children, who may have to be treated as very similar to an adult patient will require a higher cerebral perfusion pressure target, sometimes even up to 65 millimeters of mercury. So accordingly, the mean arterial pressure targets need to be optimized. The goal of fluid therapy should be to maintain neutral fluid balance. There have been certain studies showing restrictive fluid therapy, but it is important to maintain neutral fluid balance by monitoring of urine output. These patients generally have a central venous catheter, so trend of CVP can be monitored, and serum creatinine and blood urine nitrogen levels can also be monitored to look for fluid status. Regarding the choice of fluid, the initial choice is 0.9% saline, which is normal saline. But if the patient is too small, if it is an infant where there is a risk of hypoglycemia, there should be visual monitoring for hypoglycemia and serum sodium levels, and that should decide whether glucose will be required as a replacement for these patients or not. It is in this scenario that nutrition comes into play. The earlier we start enteral nutrition, the better is the prevention of hypoglycemia. And so hypoglycemia worsens neurological outcome very significantly, and that needs to be taken into care as well. And despite neutral fluid balance, if we are not able to maintain adequate mean arterial pressure or cerebral perfusion pressure, then vasopressors can be used. The most common choice is norepinephrine, and the augmentation to blood pressure targets after ensuring euvolemia is essential to prevent volume overload. Hemoglobin targets also need to be considered when we are considering hemodynamic optimization. Too much of fluid transfusion is also not going to result in good neurological outcome. We need to ensure that hemoglobin target is at least 7 milligram per deciliter. 7 milligram per deciliter sounds very conservative. It can go up to 7 to 8 milligram per deciliter as well. What about sedation and analgesia? Now, the guidelines recommend that the only recommendation that is provided by the guideline is if there is an ICP crisis, avoid bolus administration of midazolam or fentanyl. The rationale behind this guideline is that a large bolus dose of either midazolam or fentanyl may result in cerebral hypoperfusion because of hypotension and impaired autoregulation, and that in turn can worsen the vasodilatory cascade. But it is important to make sure that these patients receive adequate amount of analgesia and sedation. The most commonly used combination is of midazolam and fentanyl. Previously, drugs like ketamine were considered to be, not favorable for managing patients with TBI, but they provide good hemodynamic stability, and it can be used in combination with other agents like opioids or benzodiazepines or even propofol for that matter. And the requirement of sedation and analgesia comes from the fact that these patients have multiple invasive catheters. The trauma itself is going to cause them pain. They are mechanically ventilated. They will be in significant distress. There may be ventilator patient dysynchrony, and these patients are subjected to routine care throughout the day. So all of these interventions can result in ICP surges, and for that matter, they need to be kept on a continuous infusion of analgesic sedation. What is the role of neuromuscular blockers? Neuromuscular blocking agents are generally reserved for rapid sequence intubation, and in cases of severe lung injury where ventilation becomes very difficult, and only in that scenario neuromuscular blockers are recommended. Regarding the role of barbiturates, again, it's a level 3 evidence. It is considered as a second tier therapy where refractory intracranial hypertension arises, but in the current day of management, there are a lot of other drugs that have come into play. We use propofol commonly in our ICU. All we make sure is that the maximum dose is not exceeded, and for this matter, we try to combine propofol with other agents like opioids or even dexmedetomidine or even ketofol can be used successfully for these patients. The important point is that all of these agents except for fentanyl also have anti-seizure properties, and they provide good analgesic sedation in these conditions. What about hyperosmolar therapy? There is always a debate between hypertonic saline and mannitol. The guidelines provide recommendations only regarding the role of 3% saline or hypertonic saline. Now, mannitol, as we all know, has a good biphasic response when used for intracranial hypertension. It has rheological properties which involves reducing the blood viscosity, increasing the microperfusion, and result of it causes cerebral vasoconstriction, and that helps reduce the cerebral blood volume and the ICP. And at a later stages, it also causes its osmotic effect, which causes the intake of fluid from the extravascular to the intravascular compartment. What about hypotonic saline? Now, hypotonic saline also has the same similar rheologic and osmolar gradients as well, but it also has additional advantages in the form of restoration of normal cellular resting membrane potential and cell volume, stimulation of atrial and antidiuretic peptides, inhibition of inflammation, and enhancement of cardiac output. Now, the studies and the evidences show that the maximum tolerance of children to osmolarity with the administration of hypotonic saline can be up to 360 to 370 milliosmoles per kg, as compared with the use of mannitol, where the maximum tolerable level or toxic level is 320 milliosmoles per kg. And mannitol also has the risk of dehydration and AKI, but these were all prior considerations when patients were not subjected to neutral fluid balance. But the problems with the use of hypotonic saline is that if continuous sodium levels are increasing beyond 160, they can result in deep vein thrombosis. And if these levels extend beyond 170, they can result in anemia and thrombocytopenia. The other point of issue is that conventionally, mannitol has been used in bolus doses, used in 3 times a day or administered every 6 to 8 hours. Whereas the recommendation for hypotonic saline state that it needs to be used as a continuous infusion in a dose of 0.1 to 1 ml per kg per hour to maintain a hyperosmolar state. This is where the problem of hypernatremia occurs, and it is important to monitor the serum sodium levels continuously. Alternately, 23.4% saline can also be used as a bolus. If there is refractory intracranial hypertension, bolus of 3% saline can also be used in a dose of 2 to 5 ml per kg given over 10 to 20 minutes. The dose of 23.4% saline is 0.5 ml per kg and a maximum allowable volume is 30 ml. Are there complications with hypotonic saline? Yes, absolutely. It can also cause rebound ICP. Rapid increase in sodium can result in central pontine myelonolysis, subarachnoid hemorrhage, natriuresis, and it can also mask the development of diabetes insipidus. What about ventilation? Controlled mechanical ventilation is essential in these patients with a severe traumatic brain injury. The targets are very simple. Saturation, peripheral oxygen saturation should be more than 92% with PaO2 of 80 to 100 and PaCO2 of 35 to 40 millimeters of mercury. That means we are targeting normocapnia. The recommendation is again level 3, where prophylactic severe hyperventilation is not recommended. And if we require it, it is essential to go with advanced neuromonitoring for the evaluation of cerebral ischemia. What about seizure prophylaxis? There has always been a debate between phenytoin and levetiracetam. The recommendation is that prophylactic treatment with anti-seizure medications is suggested to reduce the incidence of early post-traumatic seizures. In children, the risk of post-traumatic seizures is slightly higher because there is an increased risk of excitotoxicity, which makes them prone to seizures, and hence administration of anti-seizure medications is essential. Levetiracetam is a good choice. We continue to use phenytoin and levetiracetam alternately because our neurosurgeons are always favorable for the use of phenytoin in these cases. Temperature management target should be normothermia. There are level 2 and level 3 recommendations for prophylactic moderate hypothermia, but hypothermia can result in other systemic complications, and hyperthermia increases the cerebral metabolic demand further. So the target should be normothermia. What about ICP monitoring? It's a level 3 recommendation for the use of ICP monitoring if available to improve overall outcomes. Most of our centers do not have ICP monitoring. We don't use ICP monitoring for pediatric TBA cases in our center. Our ICP monitors are limited, and we have a very careful patient selection. The idea is that the information derived from the monitor should permit evidence-based care. That is, whenever a surge of ICP of beyond 20 millimeters of mercury lasting for more than 5 minutes is observed, immediate measures should be undertaken for reducing the intracranial pressure. Decompressive craniectomy, it's also a level 3 evidence as far as the pediatric traumatic brain injury guidelines are concerned. Advanced neuromonitoring, we certainly don't have it in our setups very frequently, but if using, the regional brain oxygen tension should be maintained at more than 10 millimeters of mercury. The studies that suggested this a level of 10 millimeters of mercury have a very low sensitivity but a relatively high specificity for cerebral ischemia. And unfortunately, we don't have any guideline regarding the use of other advanced cerebral monitors or autoregulation based monitoring. So when do we do neuroimaging? Repeat CT scans should be done only when there is no evidence of neurological improvement after 24 hours, when there is persistent or increasing ICP, or there is an inability to assess neurological status. This is because of the use of sedation or paralytic agents. The other recommendations include CSF drainage. It is very difficult to insert external ventricular drains into the cases with the traumatic brain injury where the ventricles are compressed. And there are also risks of hemorrhage and infection. So it is not commonly used, but if available, CSF drainage is one of the early measures to reduce ICP surges. And supportive management includes early initiation of enteral nutrition. Regarding the use of corticosteroids, the adult traumatic brain injury guidelines have a very clear level 1 recommendation against the use of corticosteroids, but here there is a level 3 recommendation where they state that the use of steroids is not suggested. I think this is more in relation to the possibility of steroid deficiency in children because of adrenal insufficiency. It does not have much to do with the TBI as such. So the pathways, they have been discussed. The CPP pathway, the herniation pathway have been discussed. The most important thing is to make sure that clinical neurological examination is done frequently to look for red flag signs or signs of herniation, and essential to maintain cerebral perfusion pressure. If the CPP reduces, it is important to confirm the volume status is appropriate and start or increase the dose of vasopressor infusion. A bolus of hypotonic saline may also help to reduce the cerebral perfusion pressure. If it doesn't reduce, then we'll have to go for second-tier therapies. Second-tier therapies including repeat CT scan to look for any new lesion and proceed with surgery, or the use of barbiturate infusions, hypothermia, hyperventilation, and higher levels of osmolar therapy. We have just discussed all of these things briefly, so I'm not going to go ahead with this once again. So when to de-escalate? We have all the armamentarium with us. We have given them how long to give and when to de-escalate. Now, it is important to ensure that sedation does not stop abruptly, especially when multiple drugs are going on. The opioids can be tapered off slowly, whereas drugs like midazolam can be continued for a longer duration as they have their anti-seizure effect as well. Regarding ICP monitoring, the general duration recommended is around 3 to 5 days, and it can be considered to be removed if the ICP is stable for at least 24 hours without any surges, and correspondingly, the clinical status should be stable or improving as well. With regards to hyperosmolar therapy, mannitol is given for a duration of 3 to 5 days, but it needs to be tapered gradually. With hypotonic saline, it is important to ensure that the sodium levels are stable, and only then the infusions can be stopped. What about ventilation? Controlled ventilation needs to be continued for a period of 3 to 5 days as long as ICP control is not achieved. And it is after that that periods of weaning can be attempted, and assessment of neurological status can also be done simultaneously. Anti-seizure medications, the recommendation is to give for the prevention of post-traumatic seizures, which means we need to give it for 1 week, but in general, they are usually continued beyond the period of hospital stay as well. Now, there are some newer evidences as well. I just want to discuss briefly about them. What is the role of ICP monitoring now? This is a retrospective study that was published this year with a large sample size of around 30,000 patients, where after propensity matching, it was found that in patients where ICP was monitored, the mortality benefit was definitely identified with ICP monitoring. But the fact is that ICP monitoring led to longer, more intensive treatment, longer ICU stay, longer hospital stay, and hence more comorbid conditions in the form of complications. Post-traumatic seizures, they are most, the higher risk is those with prolonged loss of consciousness for more than 24 hours and those who return to baseline, and hence they require continuation of their anti-seizure medications for a prolonged period of time. Decompressive craniectomy has variable evidence. This meta-analysis that was published in 2025, it suggests that it may not have a significant advantage over medical management as far as mortality and long-term neurological outcome is concerned. If intensive medical management can be done, then it is as good as going ahead with surgery. This is for cases of intracranial hypertension. There are newer evidences regarding the role of ICP thresholds. it is conventionally considered that 20 millimeters of mercury was the ICP threshold for pediatric patients, but this study that was published this year in 2026 by this group, it suggests that patients with a good neurological outcome do have relatively much lower thresholds, say between 14 to 15 millimeters of mercury during the initial stage after traumatic brain injury, whereas those with the higher ICP levels did have poor neurological outcomes. And so it is suggested that for pediatric patients, the ICP threshold should be maintained even low, around 14 to 15 millimeters of mercury. And who knows, this study may be the basis of newer recommendations for reducing the ICP thresholds. The Center TBI study is the recent evidence of prospective study that is providing new evidence regarding the management of pediatric traumatic brain injury. In this study with around 4,000 patients, severe GCS was found mostly in the adolescent patients, where the toddlers and the children who had age group of less than 12 did not have that severe neurological injury. So that appears to be the general trend. And they suggest that the management of patients, these adolescents, should reflect the guidelines of adult TBI guidelines. The autoregulation based monitoring, some results are also coming up. In adults, the PRX, the pressure reactivity index, is the most commonly used. 0.2 has been identified as the ideal level, but in children, it has been found that unfavorable outcomes with PRX exceeding 0 for too long is usually possible. So with all of this evidence, what we did for our case, we mechanically ventilated our child for 3 days. With analgesic sedation, we maintained EtCO2 at around 35 millimeters of mercury, that is normocapnia. Hypotonic saline infusion was given for 48 hours and then it was stopped. Twice daily ABG was done for monitoring sodium levels and PaCO2. We provided anti-seizure prophylaxis with phenytoin, and our sedation protocol used fentanyl and midazolam. We began enteral nutrition for the child with Ryle's tube 24 hours after decompression, along with pantoprazole first salsa prophylaxis. We monitored pupillary reactivity and GCS every hour. GCS was M5 initially, which later improved for the child. So to conclude, neurocritical care management of pediatric TBI requires proper understanding of age-specific considerations. Adolescents with severe TBI may be treated in accordance with adult guidelines. Serial ongoing clinical neurological assessment with GCS and pupillary reactivity forms the major cornerstone of management. ICP monitoring is underutilized in pediatric TBI despite recommendations. And in the absence of ICP monitoring, controlled ventilation with adequate analgesic sedation, hyperosmolar therapy regimen, serial neurological monitoring, and imaging when necessary are essential components of management. Thank you.
Thank you, Dr. Jain, for this excellent and informative session, taking us through the nitty-gritties of the guidelines and all the recent updates. Over to you, chairpersons.
Excellent presentation, Dr. Jayant, and I'm thoroughly impressive, specifically regarding the management in terms of the hypertonic saline in mannitol. The concepts have been made pretty clear, as well as the role of decompressive craniotomy is concerned. Thank you so much, Dr. Jayant, and I feel that most of the things have been covered up in detail regarding the post-operative ICU management or pre-operative ICU management of any particular age group less than 12 years of age to be undertaken. Thank you so much.
Thank you, sir. Thank you so much.
Thank you, Dr. Jayant. May I now invite the final speaker of the evening, Dr. Deep Sen Gupta. He will be talking on the sequelae and the rehabilitation aspects of pediatric traumatic brain injury. He is a consultant in Asian Institute of Gastroenterology at Hyderabad. Again, a very, very intellectual guy, prolific speaker. Over to you, Dr. Deep.
Good evening, esteemed seniors and respected colleagues. I sincerely thank the Research Society of Anesthesiology along with Dr. Naveen sir, Dr. Vishal sir and Dr. Ankur sir for providing me with this opportunity. Ankur sir has been very inspirational right from our residency days. Following the commendable presentations by my fellow speakers on the critical aspects of pediatric TBI, we will now proceed on to a brief discussion regarding the outcomes, rehabilitation and future directions in this field. So what are the core clinical challenges considering the outcome rehabilitation, and future directions. So the primary ones is the growing into deficit phenomena. This is basically the deficit in the higher order functions like abstract reasoning or executive functioning, which may not appear immediately after injury. There is a developmental latency which can lead to an academic disconnect. Second is high vulnerability to secondary neurological insults. Now, these patients, they are high probability for post-traumatic epilepsy, with studies reporting the incidence to be around 10%. There is an autonomic dysregulation, while the immature pediatric brain is highly susceptible to paroxysmal sympathetic hyperactivity, cerebrovascular autoregulation, and severe cerebral edema. The third one is direct scaling failures of adult rehabilitation models. Now, most of the models which we do have right now is corresponding to the adult patients. This data gap leads to highly inconsistent and unvalidated pacing and dosing of physical, occupational, and cognitive communication therapies. There is asynchrony in multi-system care transitions as well. The neurocognitive sequelae which we talk about, the primary one is the age at injury paradox. Especially the younger children who are less than 5 years of age, they experience worse long-term neurocognitive outcomes. Growing into deficits, as we previously discussed, it is a pediatric cognitive impairment which manifests as a cumulative lag when they encounter higher scholastic and social demands. Executive function and processing speed gets affected, which is the most pervasive neurocognitive sequelae, and there is a disrupted learning and memory, which severely impacts the child's ability to acquire and retain new information at an age-appropriate pace. There is a pragmatic language development impairment. Verbal fluency in social communication exhibits long-term vulnerabilities. There is a dose-dependent trajectory as well. It has been reported in studies that mild TBI, like specifically the concussion, they resolve quickly within weeks, while the moderate to severe TBI, they demonstrate a chronic global cognitive decline, which is very important in this pediatric age group. Environmental and socio-demorphic moderation plays a significant role. High family burden, limited socioeconomic resources, and pre-injury poor adaptive functioning, they significantly worsen the neurocognitive trajectory we will discuss later. So how can we rehabilitate? So there are multi-pronged strategies have been developed. A developmentally timed reintervention strategy, direct executive function and metacognitive strategy training, family-involved brain injury training, school-centered cognitive accommodation, combined pharmacotherapy and cognitive rehabilitation, and targeted social communication training. These are the multiple legged stools on which this rehabilitation strategy is developed. Foremost of it is school reintegration. So from once the child is successfully treated and is discharged from the hospital, the reintegration into school plays a cornerstone model in the development of their future personality. The multidisciplinary liaison model plays a significant role here. The primary goal is to ensure everyone understands the child's specific cognitive requirements. How do we develop this multidisciplinary liaison model? One thing which has been proposed is the school should have the receiving school, that is the classroom teacher who's the part of the school TBI team, the neuropsychologist, the speech language pathologist, specialized school nurse, and resource educator. So these teams, they combine the school TBI team, which should be in the receiving school which the child is going to. The reintegration is graduated on return to learn framework. It is a home-based cognitive resting, followed by brief school exposure for shorter periods of time, slowly upgrading to full day attendance with maximum accommodations, and finally full attendance with step-down supports, while the support that the school TBI team slowly withdrawing and letting the child be a full individual. There should be a formal legislative and educational accommodation as well for such children. Pediatric TBI is uniquely unpredictable. The child's need may change dramatically over weeks or months. As I said, growing into the deficits. Accommodations must be individualized. It can be an informal adjustment temporarily, which are updated weekly, which are transitioned to formal long-term educational plans if deficits persist past then 3 to 6 months. And the workload reduction, shorted assignments focusing on mastery rather than repetition. There should be a vigilance for the delayed growing into deficits, which a child who can initially appear fully recovered in the elementary school may begin to struggle significantly later. What we call it as a transition cliff from primary to middle or high school. It entails multiple teachers, self-directed long-term projects, and complex abstract reasoning as the child progresses from primary to the middle school to the rigors of high school. And the latent executive function may get unmasked following the traumatic brain injury suffered in the childhood. Longitudinal tracking is important. Annual or biennial academic and neuropsychological screening post-injury. Emerging academic failures may be a part of neurocognitive sequelae, which must be understood by both the parents as well as the school. And it must not be attributed to a lack of motivation, behavioral issues, or oppositional defiance. So, coming to the family-centered care. Family plays a significant role in the rehabilitation and ultimately a proper outcome. The four-legged stool here is shared decision-making between the parents, collaborative goal setting, the sibling and systemic dynamics, and translation to the long-term self-management. The family-centered care is basically a weighing balance between a family dysfunction, parental distress, or socioeconomic burden, working against a stable, supportive family environment. Now, these two make sure whether the optimization of child's neuroplastic recovery is at its full capacity. One of the programs which I found in a recent study was iInteract protocol. So basically it consists of 10 core sessions and 7 supplemental sessions. The core sessions are designed to garner positive parenting skills, consistent discipline techniques, and antecedent behavior management. They primarily emphasize on identifying antecedents to behavioral dysregulation and developing strategies for setting the child up for success. So what are these sessions? I'll briefly just enumerate them. So session 1, the home visit, it is introduction to the iInteract program. Session 2, online, it is positive parenting skills and spatial playtime. The session 3, again online, staying positive and coping with stress. Session 4, online, it is behavioral management. Session 5, it is introduction to lead your child, parent-directed interaction. Session 6, it is dealing with anger. Session 7, introduction to consequences for not following directions, followed by cognitive problems, house rules, and using positive parenting skills in real life, and so on and so forth. What are the prognostication challenges? The primarily we can divide it as because of the developing brain or growing into deficits, which is the foremost prognostication challenge. It delays the unmasking of the deficits. There are limitations of clinical scales. The infants and toddlers, they are verbally or developmentally immature. The non-linear injury to outcome relationship, the rejection of the plasticity buffer. This basically that young children, that because of their enhanced neuroplasticity, they recover well. But various studies have proved that it may not be so all the time. And confounding environmental and pre-injury vectors. Then the future directions. The future directions being the primary ones being the biomarkers. I will just focus on the most prominent ones. First one is glial fibrillary acidic protein. It's an astroglial intermediate filament and ubiquitin C terminal hydrolase L1, which is a neuronal cytoplasmic enzyme. And finally, the neurofilament light chain. So the UCHL1, its primary cellular source is neuronal soma. The peak kinetic window, the sharp spikes is seen. Primary predictive utility is in acute neuronal necrosis and structural lesion dryage. The GFAP, astrocytes is the primary cellular source. The peaking levels are between 20 to 24 hours. And predictive utility is in blood-brain barrier integrity and astrocytic reactivity. NFL, myelinated axons are the primary cellular source. It is a subacute elevation. It peaks over days to weeks, and it is primarily in predictive utilities in chronicity of white matter injury. The one which is traditionally the S100B biomarker, which is traditionally used, it is for adult TBIs, it is fine, but for children, it is a scaled down protocol because they fail in children because the active growth skews the numbers. And therefore, the above 3 markers are more suited for pediatric biomarker prediction. Finally, the AI in pediatric TBI. So how the artificial intelligence in this world and age, how it is helping in pediatric TBI. So basically it works on 3 principles: improved precision, optimizing the emergency triage, and reducing the radiation exposure. As Barkha ma'am previously said that the children less than 5 years of age when exposed to multiple CT scans, they have a vulnerability to injury or radiation-induced injury. So clinical decision support and triage optimization, they refine the criteria for when to order an emergency head CT. They enhance the pediatric emergency care applied research network rules, the PCAN rules, as again discussed previously by Madam, to identify the children at very low risk for clinically important TBIs. And one of the studies, the sensitivity and specificity have shown to be pretty high, approximately 98.6% and 99.7% respectively, in predicting the necessity of a CT scan. The other advantages being advanced neuroimaging and precision analytics, automated lesion segmentation. These are deep learning models which achieve high precision in segmenting traumatic subdural or epidural hematomas, contusions, and surrounding pericontusional edema. They also help in quantification of mass effect and shift, and they eliminate the inter-observer variability. And dose optimization via GANs, generative adversarial networks, to reconstruct high-quality diagnostic images from low-dose CT scans. The potential to reduce pediatric radiation exposure by 36 to 70% without sacrificing critical diagnostic detail. Critical care and neuromonitoring and multimodal integration, AI again plays a very important role here. Focus is to prevent the secondary brain injury. Machine learning algorithms, they continuously analyze high frequency physiological data such as ICP wave, morphology, CPP, end-tidal CO2s, and arterial blood pressure. They identify subtle dynamic patterns that precede acute intracranial hypertension and episodes of impaired cerebral autoregulation. They also provide with automated scoring systems and prognostication and outcome modeling. So that is the good parts of AI, but we are more supposed to understand what are the key challenges which this AI poses and the present medical and medico-legal personality right now. Anatomical and physiological heterogeneity, the models trained primarily on adult data or narrow pediatric cohort, they struggle with generalizability across different age groups. The key term which the text use is the black box dilemma. It is basically the problem how the AI arrives to a decision or a prediction or a diagnosis, but the internal mechanism or the algorithm it used to get there are too complex for humans to understand or trace. And therefore, the key challenges come to be the trust deficit, difficulty in troubleshooting, bias in fairness, and regulatory and liability hurdles. Coming to the final topic, the long-term quality of life in pediatric TBI. So cognitive and executive functioning are definitely taking a hit here. The growing into deficits phenomena must significantly be concerned. The deficits in abstract reasoning, long-term planning, and working memory may not become apparent until middle or high school. Academic trajectory, which may present with deficits in processing speed, attention, and cognitive flexibility, significantly hinder the academic and future career milestone achievements. Behavioral and emotional regulation. Internalization versus externalizing the behavior. Long-term survivors, they show significantly higher rates of depression, anxiety, and social withdrawal. That is what internalizing, as well as impulsivity, aggression, and oppositional defiance. That is what the externalizing. So they may bifurcate in these two personality traits. They can also lead to social isolation. Physical and somatical health. So long-term survivors, they usually tend to present with chronic fatigue and sleep disturbances. Endocrine dysregulation, post-traumatic hypopituitarism is quite common, particularly because of vulnerability of the pituitary stalk to get injured in severe TBIs. Persistent somatic symptoms, chronic post-traumatic headache, vestibular or visual processing issues, they can severely restrict participation in sports, hobbies, normal adolescent activities. Family system and caregiver burden, the caregiver toll. Parents, we must not forget, they are frequently experiencing chronic stress, anxiety, and financial strain because of this entire situation. And family functioning as a predictor, as we've said, the socio-demographic moderation, the studies, they consistently show that long-term pediatric quality of life is highly correlated with the pre-injury and post-injury family environment. So in one of the studies published in Pediatric Neurology, so the adult milestone of educational attainment, the moderate to severe pediatric cohort, as we said, the mild ones or the concussion ones, they recover fairly properly, but the moderate to severe ones, they tend to have pervasive neurocognitive sequelae. The educational attainment, that significantly lower rates of higher education completion is seen in pediatric cohorts. Increased reliance on vocational or modified academic pathways are needed. Employment and finances, higher rates of underemployment or long-term unemployment is seen, which is strongly mediated by persistent executive dysfunction and slow processing speed, making them more difficult to hold on to jobs or excel in their particular skill. Independent living, again, a substantial portion of individuals injured in early childhood continue to require residential or financial scaffolding from parents well into their 20s and 30s, while for a normal cohort, they are quite independent at that age group. And marital status, lower rates of long-term partner relationships and higher self-reported rates of social alienation, particularly stemming from the fact of internalization and externalization, social personality behavior. Thank you.
Thank you, Dr. Deep. Excellent presentation. We have always been involved in the neurocritical care management of pediatric traumatic brain injuries But then a second journey of these children takes place when they are discharged from the ICU. And unfortunately, we in India, we are not much into rehabilitation, and there is a gross ignorance, or probably not much of the people are interested in rehabilitation of these people. But then it is a burden on the family to take care of these children, and that is why the whole purpose was to bring insight as to what happens after this patients are discharged from the ICU. A lot of neurological sequelae involving organ damages, psychosomatic symptoms, and withdrawal from school. So many things happen, and that's why the appropriate concept of rehabilitation needs to be emphasized again and again by all stakeholders, including us. Over to you, chairpersons.
Dr. Swati?
Yes. Uh, Excellent presentation. I think the choice of topics, Dr. Ankur, first of all, I think you have done that, and it's excellent because many of these topics, especially in pediatric TBI, which in itself is a very less discussed topic, and then going to the extent of AI in pediatric rehabilitation, this is something only you could have pulled off, and choosing the speakers, excellent speakers for each topic. And I see there is one question in the chat box wherein Dr. Sundareshwaran Sundar has asked, the BP may be already low in children and infants post injury after hemorrhage. What about the permissive hypotension in these scenarios? Do you want to take that, Dr. Jayan?
Permissive hypotension, I don't think we are actually following it in any of the TBI cases, let alone pediatric. So yeah, as said, the BP is already low, and it's important to maintain the MAP and CPP target. So we have discussed that the CPP target should be somewhere between 40 and 50. So we can't go any lower. This range is given only because we don't want to get into the lower end of the range. So this probably doesn't apply to pediatric cases, this concept of permissive hypotension.
Yeah, very true. So essentially, that's what we have to maintain. When there is a CPP based management, then we have to maintain the blood pressure at all times. Yeah.
One more
So-
important thing is there. The thing is that when the skull is fused or when the skull is not fused. So that particular consideration also comes over when we are dealing with pediatric traumatic brain injury. So brain has got a pliability actually to expand. And sometimes the cerebral edema is there, but it is not featured that much because of the pliability of the skull. Then, and obviously we have to maintain the CPP. So we have to maintain the mean arterial pressure at all times.
Yeah, correctly pointed out, Dr. Mayank sir, and very well answered, Dr. Jayant. We usually are not much into permissive hypotension nowadays. It's being discouraged until and unless in the intraoperative period, if there is tremendous amount of blood loss and we need to momentarily reduce it for controlling the bleeding. Otherwise, it's practically not done nowadays. So the house is open for discussions. Anyone who is having any query, kindly unmute and straight away ask the queries or any compliments, comments for the speakers. I have a small disclosure to make. The idea of selecting the speakers, I have been very close to Dr. Barkha ma'am. She was my senior in AIIMS Delhi when I was doing my DM residency. Dr. Jayant and Dr. Deep Sen Gupta were my juniors. But then it's not because we are from the same department. It's because I have seen their work, very hardworking, very intellectuals, and they are doing such good works in their respective centers in different corners of the country. So I wish uh, lots and lots of future works for all of them, and keep continuing the good work. And I also thank this all the GC members of RSA for actively participating in the webinars. I can see the names: Dr. Amit Kohli sir, Dr. Nishan Sai sir, Dr. Parul ma'am, and all other members. Pardon me if I've missed any name. So please unmute and put forth your queries and any comments for the speakers. So my query to Dr. Burkha ma'am, why is the first 72 hours of any traumatic brain injury so important? And it is said that the maximal damage or reperfusion injuries occur in the 72 hours. How are we going to tackle these first 72 hours depending on the severity of injury? Suppose vis-a-vis mild injury versus moderate injury, how do you tackle these first 72 hours?
So basically, as I discussed, the primary brain injury part is something that cannot be helped. It is only the secondary brain injury that is where we actually act, and which is the only part of the entire scenario that can be prevented. So once there is a primary injury, it is in the first 2 to 3 days that any episode of hypoxia, hypotension, or hypoglycemia, or all those factors that can cause secondary injury to the brain. So these are the first 2 to 3 days wherein these things have to be actually managed, and it is also uh, the uh, edema that is associated with brain injury, or as we saw, the incidence of DAI is very high in pediatric patients. So all these things, which are sort of the side effects of the actual injury per se, these tend to come into the picture in the first 2 to 3 days. For example, there is a small contusion, but then the surrounding edema starts manifesting not exactly at the time of injury, but gradually later on. So that is why probably it is that the first 2 to 3 days are very important. After that, along with all the interventions that we do, the brain itself probably tries to start healing itself.
Dr. Jayant, in your neurocritical care setup, when do you plan tracheostomy if at any point of time you feel that this patient is not feasible for extubation? What is that demarcation of duration when you plan tracheostomy for children? Do you give more time to children for extubation as compared to adults, or you do early tracheostomy in children?
In comparison to adults, there is a relatively longer period of time before we decide on going ahead with tracheostomy. Of course, in adults, we try to go ahead with early tracheostomy, and in fact, what we are doing is earlier tracheostomy. Around 72 hours is what we are doing, or even sometimes earlier than that. But in pediatrics, I think we do give a little bit more time to for the interventions. We continue with the aggressive interventions with ventilation and optimization of hemodynamics, and only after that we decide on consultation of tracheostomy. I should disclose that the number of cases that we are dealing in our center with pediatric TBI is limited, but in those cases it is with the adolescents who come now, like this 7-year-old boy we know we wanted to continue ventilation for, I think we ventilated him for almost 5 days, and after that we were able to give him a trial of extubation as well. We were able to extubate, but we generally tend to go with a slightly longer period of oral intubation in these patients before consulting tracheostomy.
Even we do the same. We give a longer time to children. They tend to make good recovery, and that's why we prolong the time to tracheostomy in children, unlike adults where we know this patient is not going to improve in the very early period, and we do tracheostomy a bit early. Barkha ma'am, what is your experience of decompressive craniectomy? Previously, we used to see lots and lots of decompressive craniectomy in children, but emerging guidelines and emerging evidence over the last, say, 8 to 10 years have drastically cut down the decompressive craniectomy and put forth the priorities on medical management. Your take on it?
I think yes, what you said is right, that the number of cases of decompressive craniectomy in pediatric patients is definitely much lower compared to that in adult patients. But I think there are multiple reasons to it. One is that the incidence of pediatric TBI itself is lesser compared to that in adult TBI. The second one is, we know the skull compliance is good in children, so that probably stops us from going in for an invasive procedure immediately. And yes, the incidence, as you said, is definitely lower compared to adults. And one thing I wanted to just add about the previous question about the tracheostomy in pediatric patients. Yes, we do wait a little longer in pediatric patients, but one very important concern that comes in here is that the ET tubes are very thin. So, and whether we accept it or not, but the tubes definitely get blocked by the time it is day 2 or day 3. Those small 3.5, 4 mm, 5 mm tubes. So we do tracheostomy slightly early. I think we don't wait until 4 or 5 days. If we see that the child is not going to get extubated, we're going for tracheostomy.
Thank you, ma'am. Thank you for your inputs. And there is a very nice input from Dr. Nishant Sahay sir. He said that airway intervention should always be held together with cervical spine immobilization. There is always an emphasis from the ATLS that cervical spine immobilization should always be along with airway management, and collar should be removed only when cervical spine injury has been excluded. Dr. Deep, in your center, when you discharge your patients from the neurocritical care, this is my final question. And what is the period of follow-ups you ask them to visit your center at 3 months, at 6 months, and what specifically you look into those patients? Kindly unmute Dr. Deep.
So, sir, at the time of discharge, it basically depends what is the discharging GCS and what condition they're getting discharged. And for mild TBI, which those who have recovered well, they are coming to back to the OPDs as per the surgical discretion. Usually, what they call back is within first in 7 days, 1 week, and then after 1 month. And depending on that, they'll repeat a CT and MRI. For the poorer ones with moderate to severe ones who are tracheostomized or having a poor GCS, we usually discharge them. We counsel the parents thoroughly, and we outsource our rehabilitation to a private center here, who takes care of this. And we counsel the family, and then we discharge it to there. And from there, they slowly go into this rehabilitation, and step by step they come out of it. To be very frank, the complete recovery right up to school reintegration and all, I haven't personally seen. We have only discharged in a stable state to the rehabilitation center, and from there they usually follow up. From medical legal point of view and from clinical point of view, the child is alive, and that's what where we do not follow beyond that. But yes, if any deterioration happens and if they come back, then we get to follow them again. But otherwise, they continue with rehabilitation, and then so on. They follow it with the rehab team there.
Thank you, Dr. Deep. And with the advancement of AI, I'm sure AI will bring lots and lots of help to the clinicians with predictive models, the management models, and of course the rehabilitative models. Before I put my vote of thanks, I request Professor Naveen Malhotra sir to kindly speak few words on these presentations. Kindly unmute, sir. Yeah.
Thank you, Ankur, and heartiest congratulations to all the speakers and well moderated by the chairpersons. I also learned personally from you youngsters. Thank you very much. God bless you. Keep on doing good work.
Thank you so much, sir. Sir has always been an inspiration, a guiding force, a motivator who has always held his hands for us and always guided us in all our steps. Thank you so much, sir, for your blessings and guidance always. My request to Dr. Vishal Singla, sir, for this webinar.
Thank you very much, Dr. Ankur Khandelwal, for organizing such a wonderful webinar, and also heartiest congratulations to Team Guwahati for conducting this webinar. I'm sure all the anesthesiologists and also the especially the PG students would learn a lot. As Madam Indrani said that we have been dealing with adult TBI quite frequently, but pediatric TBI is one subject where less of information and knowledge is there. I'm sure this webinar was was a great wisdom booming to all the participants. Thank you very much, Team Guwahati.
Thank you so
And,
much, sir, for the kind words and for the opportunity as well. So I thank finally all the chairpersons, Dr. Swati, Dr. Mayank sir, and all the
Thank you so
speakers,
much.
Dr. Barkha, Dr. Jayant, and Dr. Deepsen Gupta for your valuable inputs, your time, and putting forth so much of information. I'm sure all the delegates would have important take-home messages from this webinar and will inculcate in this their clinical practices. I thank all the delegates, all the members of RSA for participating in the webinar. Thank you so much. Till we meet next, have a very good evening and days ahead. Thank you so much.
Thank you, sir. Thank you.
Thank you so much, Dr. Ankur. It was a real
thank you very
pleasure.
much,
Thank you so
everyone,
much,
and
Malhotra
long
sir
live
and
RSA.
Vishal.
Long live RSA.
Long live
Long
RSA.
live
Thank you very
RSA.
much. Thank you very much.
Thank you.